rationale for using Ibrutinib and Rituximab for this young patient with progressive and symptomatic CLL comes from a series of trials, but most prominently the recent study that was presented at the ASH meeting by Dr. Shanafelt. This study compared Ibrutinib and Rituximab in symptomatic patients who required treatment to fludarabine, Cytoxan, and Rituxan, which was the gold standard until this time. In this study, we saw some really dramatic differences. We saw an improvement in progression-free survival for the patient population at large, but also when we looked at the subgroups, we saw that virtually every subgroup that was tested, whether someone was old or they were young, whether they had a good performance status or poor, whether they had high-risk cytogenetics or not, all the subgroups benefited from treatment with Ibrutinib and Rituximab. There's one subgroup that probably bears a little bit more discussion, and that has to do with the mutated patients who had mutated immunoglobulin heavy chain. These are patients that we normally think of having good risk for their CLL. If we look at some of the follow-up from long-term follow-up from studies, some of the studies conducted with fludarabine, Cytoxan, and Rituxan, FCR, we see that a subgroup of those patients have a plateau in their survival curve, and as well as their progression-free survival curve, suggesting some patients treated with very good risk CLL, treated with FCR, that they may never relapse and they may go on for many, many years without needing therapy. And this is a controversial group of patients because when you treat someone with Ibrutinib and Rituximab, then you're really committing them to therapy for a very long period of time, as long as they're not having adverse events. And so some people have questioned, but in this study, even in that mutated immunoglobulin heavy chain group, those patients appear to benefit from the Ibrutinib and Rituximab investigational treatment. So personally, I use single agent Ibrutinib rather than Ibrutinib and Rituximab. This is based on a couple other studies. One was the study from the Alliance group where they compared bendamustine and Rituximab to Ibrutinib and Rituximab. And in that study, they saw no difference between the Ibrutinib group and the Ibrutinib and Rituximab group. Both groups did much, much better than the bendamustine and Rituximab in terms of progression-free survival. And so from that, it doesn't really look like the addition of Rituximab to Ibrutinib adds much to Ibrutinib alone. This is also seconded by data from the MD Anderson, where the addition of Rituximab did not seem to improve outcomes for patients who are treated with Ibrutinib. So Ibrutinib alone did just as well as Ibrutinib with Rituximab.